Our next contestant, Roni Atali from Aisap. Aisap solution is empowering clinicians with AI at the point of care, anywhere, anytime.
So thank you, first of all, for inviting me today. I'd like to discuss and tell you a little bit about Aisap, which is a company that I actually only joined in the last 5.5 months, but it's a brilliant company that was founded at Sheba by these amazing people. You can see here on the left, Adiel Shalom, which is sitting in the audience, and is our brilliant tech guy, and the leading cardiologists of Sheba, Udi Ra'anani and Professor Klempner, which are leading cardiologists at Sheba. The company was built with really a specific pain point that was addressed. And the specific pain point is actually low access to imaging worldwide. So we know today that there's just simply not enough to go around, and not everybody that needs to get some sort of a scan or a diagnosis based on a scan can actually get it. And for this reason, a revolution has already started a few years back using what's called point-of-care ultrasound. So these are little ultrasound devices. They can connect to your laptops. They can also connect to your cell phone or even carts, which you can see in emergency rooms, people bringing them up and doing the diagnostics at the point of care. So the revolution kind of started, but it hasn't really begun completely, and it hasn't really rised. And the reason for that is that the physician or the intended users that are using these point-of-care ultrasounds are not radiologists, and they're not cardiologists, and they're not technicians. So two problems arise. The first one, they don't really know how to scan correctly, and they're not really sure that what they're acquiring is good enough for analysis. Okay, they're not sure that they're seeing everything, and kind of ultrasound is kind of in the eye of the beholder, so not every time they'll get a standardized image. So that's one problem. The second problem is that they don't know how to interpret. Again, they're not cardiologists, they're not radiologists. They can interpret not everything, and they don't really feel comfortable with what they're interpreting. And that's where actually Aisap comes in. So with our first product called POCAD, which is a point-of-care assisted diagnostics, where what we're doing is addressing these two issues. And I'll show you that in just a bit. Unfortunately, I can't demo here because I can't take someone's shirt off and start scanning him, but I can show you how the application looks. So what we're doing in this point-of-care assisted diagnostics is doing complete diagnostics at the point of care. With our first application that you could probably think, since it started at the cardiology department of Sheba, is a cardiac application. So an almost complete echo in just 5 minutes at the point of care, at the bedside, next to the patient. So again, this is the intended user here is the physician, not the expert cardiologist or radiologist. So we need to do very quick training, and we can do this training in just about 2 hours. And the views that they have to acquire are only between 3 and 4. So a standard echo, you have to do 9 different views, and this is quite difficult for someone working in the ED, which has to now scan and go to his next patient. So we do it in only 3 to 4 views and in 5 minutes. And this is how it looks. It's 4 different steps. The first steps gives you a real live indication score, which tells you you're scanning correctly. It's kind of like a clock which goes up, and when it hits the 80%, you know to record this loop right now. So right now, you're really standardizing the echo loops that you're recording, and the physician kind of has a feedback loop letting him know, listen, you're scanning correctly. The second step is the diagnosis. And you can see here, we're not just triaging or just telling them, oh, you have something in the aorta or something in the atrium. We're really giving them the severity of the implication. Okay, so whether it's normal, mild, moderate, or severe. So we really are doing complete diagnostics and not just triage. The third step, we let the physician approve what we found. And then the fourth step, which is quite valuable in the US, is that we print out billable reports, which we can inject into the EMR. So 4 quick steps in just 5 minutes. You can see here the indications that we diagnose. This is about 85% of a full echo exam. After many surveys that we've done, this is enough to make a decision at the point of care. So for more difficult stuff, they would have to at some point maybe, if needed, get a full echo. But you can imagine now that if a person and the people, patients at the ED or in the internal medicine can get scanned in about 5 minutes, we can, 1, save unnecessary echoes, and 2, really make the decision at the point of care. So just a little bit about early clinical research that we've done. This is a study that was done in Sheba, a 1,300 patient prospective study. And what we found out of this, and these were people that were not triaged to full echo. So they had some sort of a small cardiac indication, but they were probably not get echo, maybe in a few weeks later, but they would probably not have gotten echo right now when they were at Sheba. So what we found out of this cohort of patients is that 35% of them, we found some sort of a new moderate condition. 27% of them, their clinical discharge or their management was changed, whether they were discharged earlier, whether they were giving different, admitted into some sort of a procedure, or maybe given a different form of treatment. And what's even more important on the ROI aspect is that what we found, we went really into the patient records and looked to see what was a procedure that was done by an Aisap-driven procedure that was done ahead of time in the observation unit. And what we found was for each $1 that Sheba pays us, we're actually paying them back to, times 2.5 in US dollars per year. So that means when we're looking at this, we're only looking at procedures that were done because they were driven by Aisap. Again, these were not patients that would have gotten a full echo while they are at the time they spent at Sheba. A little bit about our competitive landscape. Yes, ultrasound is a big thing today. Many companies in the field are trying to do different things in the areas of ultrasound, but looking at the space of interpretation and diagnostics at the point of care, we're pretty much at a blue ocean. There's not many companies which are doing complete diagnostics and severity of the indications at the point of care. Again, one of our big value differentiations is that we're also looking at the valves and all the valvular pathologies, which is something that we have to do at deep learning, and it's not done a lot outside in the other companies. Just to give a couple more minutes to let you understand that we're not just a cardiac company, but the vision of the company is we're kind of Star Trek geeks. So the vision of the company is to really be the next tricorder, where I can go beep, 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 and tell you, okay, you have something in the heart, something in the abdomen, something that's vascular. We're already working on our Nest application, which is a vascular application. We're looking at DVT and AAA, and hopefully on our way to scan the whole body and really be the point of care platform where we can really diagnose whatever is needed in just a few minutes at the point of care and kind of be the next tricorder or the next stethoscope, if you'd like. And for my last slide, you can see we're quite a young company. We were founded in 2022. We already submitted our FDA about a month and a half ago. We got the Israeli AMAR. We're commercially available at Sheba, and we are now talking to 3 other hospitals in Israel about commercialization. And you can see we've advanced quite quickly. We have 4 value proposition studies right now in the US and some more that we're adding. In our market, of course, we are a B2B. You'll probably ask me that. We're a B2B we're starting with the larger academic hospitals, but we know that probably our biggest value proposition will actually be the primary care and the rural, where there's just no access to cardiologists and radiologists. Okay, so we know we have a large value proposition, but we know that in the ED departments, in the internal medicine units, in the hospitals in the US, they're already using point of care ultrasound, but not making a decision based upon it. And that's where we think we can help and assist the physicians. So thank you. Look at it as a 3-way process. So first, the indication, which is real-time indication, assisting them. And this was actually something that was done, that we developed after we started doing our cardiac application, because we saw that the physicians needed some sort of a feedback loop, which showed them, listen, what you're acquiring right now is good, keep going. Okay, so it's there. Obviously on the algorithms, okay, we have 12 different indications with a CADX and LLZ combined FDA submission, quite a big one. And after that, right, as a result of that, obviously, this report that we can do in helping to standardize, and you can ask about billing, for instance. So in the US, they're not billing for POCUS. Why? There's no standardization. They're not recording it. It's not injected anywhere. They're eyeballing. From a medical legal wise, this is a very big problem. Okay, so here, again, money, on the floor where they can bill for these POCUSes where they're not doing it today. So it's really in all 3 layers. So right now, the FDA, it doesn't have to be a physician. It could be, for instance, a nurse or a nurse practitioner, but it has to be somebody that got some sort of an accreditation on POCUS. So it can't be me. Well, me maybe, but it can't be just, somebody at home. And I don't think that at this point, the intended user is the home user, but, a professional. It can be a primary care physician, but yeah, or a nurse. No, that's the thing. So you can imagine a world where the primary care physician, where you're coming into the primary care physician and you're telling him, I have a little bit of a chest pain. And instead of him having to send you to an full echo at the hospital, he can do it there, right? In his office. Yeah, the interpretation is almost 90% of a full echo, right? So if you're asking the accuracy or you're asking the... So yes, it's a decision support tool for accredited physicians, nurses, whatever. They are already using point of care ultrasound, okay? It's a standard of care, right? We are helping them make decisions based, more educated decisions made based on point of care ultrasound. We didn't invent the point of care ultrasound, but yeah.